within a week or so.
Thank you, Jasmine.
Certainly.
And then I think Lindsay wanted to give an update as an addendum to her presentation. Go ahead, Lindsay.
There we go. I'm unmuted now. Hi, everyone. I think I called this while I was doing my pre-recording, but as I had probably anticipated, on around February 1st, Cabenuva did get the FDA approval for the every 8-week injections for treatment as well. I said it might be coming and it finally did come. Of course, it was like a week after I did my recording, so I couldn't add that into my slides, but it is existing alongside the monthly dosing regimen now. So at this point in time, there is an option to do either the Q4 weeks or the Q8 weeks, though the dose would be different. The Q8 week dose is that little bit higher dose that we currently use as kind of a loading dose. So at this point, it's just up to the patients and the providers to determine which scheduling works best. And if you've got somebody who's already on the monthly and they want to do every 2 months, you just switch them over to the new dose next time and go from there. So I did just want to add that in case people are taking notes on the slide, just write down that you can do every 8 weeks now. Regarding now I'm getting questions about it right now, about the insurance. So I've been told by ViiV that you should at least try to check and see if you need a new PA. For the different NDC number, since they're the same drug code as in J code for the medical benefit, but they're a different NDC number for the pharmacy benefit. So there is a chance that the insurance may require a new PA, but in my experience, I've checked a couple formularies for my current patients and they've all had the same approval criteria and they're all able to kind of slide over if they want to. And I'm looking at Rob's question right now. What would be an advantage to Q4 dosing now that Q8 is available? That is patient preference. Honestly, I did just look over the data and there's really no difference in injection site reactions between either, which I was worried at first because it's a little bit higher volume that potentially, maybe with more volume on each side, it may hurt a little more, but that doesn't appear to be the case. Sometimes conceptually, I feel like it may be a little bit harder to remember like every other month versus every month when we tend to function in monthly intervals, just as people, paying bills and stuff like that. But honestly, unless a patient absolutely wants to stay monthly, I would probably encourage people to do every other because it is more advantageous for the patient in terms of their scheduling healthcare exposures during a pandemic and for staffing as well, since it would be one injection, every 2 months, and we could stagger appointments around, and from workload standpoint, it would be kind of the same thing, just fewer times per month. So that's just my opinion. I can mute myself if anybody else wants to talk.
Anyone else have questions for Lindsay or Jasmine? Anything else from you, Evelyn?
I'm trying to see how I can formulate my question. I do have, Jasmine, if we have, or any other agencies, if they have a patient who's being treated with this injection, do they contact you, or do they just contact the regular VMAP team?
If they have any questions, they can actually contact the actual VMAP team, and I can provide their contact in a chat.
That would be great.
Certainly.
Another question.
If any provider has any questions about procurement or about the process or the policy, they can contact me. And I can also put my contact in the chat too as well.
That would be great. Thank you so much.
Of course.
Because I know that's one of the things that a lot of agencies probably going to struggle with is since it's a new it's a new drug on the market, and And I know in our clinic at UVA, we're still experimenting with it. And as Lindsay mentioned, sometimes it does come with a little bit of a workflow challenge. So I just wanted to make sure that we're able to provide as much information as we can to the team so they know how to navigate this once they start implementing this process on their end. So that's great. Thank you so much.
Yes, of course.
I do want to address I see the question about it ever being allowed at home. I honestly don't know. I think it'd be really tricky because with it being a gluteal injection, it would essentially probably have to be administered by another person. And because of the route of administration being intramuscular, that makes it a little more complicated as well. Most home injectable products are subcutaneous, which is just a slightly different technique with how you angle the needle and everything. I currently can't think of any medications that are intramuscular injections and also allowed for home administration. And in that case, they're usually healthcare center. A caveat could potentially be if there's like a home health nurse to do it, because sometimes infusion products go that way for people that leave hospitals on IV antibiotics and things like that. But I think just the kind of trickiness of the administration, the fact that it's on both sides where a patient can't really reach themselves will make that pretty inconvenient / impossible, at least for now. If they ever reformulate long-acting ART into subcutaneous or something like that, then maybe maybe that's a potential, but I don't really see that happening with Cabenuva.
Hey, Lindsay,
Did you address Rodney's question? I believe you did, but I just wanted to make sure there's two back to back. There's one from Rodney, there's one from Temika about the advantage of Q4 dosing now that is Q8 is available.
Yeah, I addressed that one. And then with the insurance company, that was kind of dependent on the individual companies, but in most cases, it appears not to be an issue right now. The answer to the Apretude question, which is just to give the background, Apretude is the cabotegravir by itself, long-acting injectable for the purpose of PrEP. That, as far as I'm aware, I admit I haven't looked a ton into that labeling since I focused essentially on the Cabenuva treatment route, but they would have to do like the oral lead-in of the cabotegravir, just like they kind of do with the Cabenuva, but they don't necessarily have to be on like Truvada or Descovy first, from what I'm aware of. Now, insurances can make that a little bit tricky, of course. Like there may be individual insurance plans that give a PA requirement saying, why can't you be on Truvada or Descovy first if they're necessarily cheaper, but from a clinical standpoint, it would be kind of the similar assessment of tolerability first with the oral medications and then kind of moving into the long-acting injectable.
Just so folks know, it looks like Jasmine put her contact information in the chat for folks who want to make a note of that. Thank you for sharing that.
Maybe touch on, maybe are there any other people on this in this presentation that maybe have experimented this in their own clinic? Maybe they want to share how that process has worked for them.
Can you say that again?
As I said, is there anyone on this in this meeting that has maybe is implemented Cabenuva in their own clinic, similar to what we've done here at UVA, and maybe share how that process has worked or is working?
We do it here. I'm Tamika. I'm from Daily Planet. I'm the medical case manager here, and we have started it. And wow, I saw on, I think Lindsay's, she had a spreadsheet, and I quickly started making my spreadsheet because I only have 3 clients, and it makes so much sense for me to be able to keep it up because we're smaller. So like I'm a 1-person team when it comes to this. And from what just that fast of making my spreadsheet, I've got people started on their lead in within 1 month from the start date, but they had Medicare and Medicaid, which the process is like streamlined, easy for that process that I found. And then I use Vive, the rep. They're amazing. They're my backbone when it comes to Cabenuva. And I just started a new one this week for somebody who has Medicaid. So I will see how that process goes as well. But I'm excited. I look forward to. I do the injections as myself. And when I found out that the one with the R, I can't remember, Pivavir. When I found that one was thicker, it makes sense because for me, I always give the R in the right hip and then the other one in the left hip. And she came back the next week and said her right side was hurting for like 3 days. So it totally made sense. And I didn't know that part first. So I'm just excited about this process. And I was really excited to learn more and put more pieces of the puzzle together for me in my head.
Thanks for sharing that, Tamika. I feel like I resonate with you on so many levels of, trying to manage like all the aspects of it and all these patients and having essentially a smaller load. I mean, we're only at now 5 I have a 5th almost starting oral lead-in next week. It's really cool that you've sort of noticed the difference with the rilpivirine as well. I didn't know that until I was preparing for this talk, like that little logistic, because the patient was like the big one. And I'm like, they're the same volume. So like it totally makes sense with the one being thicker. I'm like, oh, I get it now. And, do you ever alternate injection sites for that purpose? Like switch it up like left and right each time?
So I have not yet. Today, actually, the person got their second injection. So the provider is doing it for me. So I've just been available for moral support. She was pretty excited about doing that. But no, I haven't. I probably can start doing that. I'm about to do the second one, I think next week for another patient. So I probably do, but just to start off, it was easier for me to do the R for the right hip, just for documentation purposes.
Yeah, it's something I didn't necessarily think about at first until I was like, oh, like maybe we should be tracking like which one goes into which, side for side effect tracking, and then kind of thought about some trends like similar to what you've experienced. I will directly quote one of our patients who said, I think after his very first injection, he was like, I feel like I've worked out for the first time after 10 years and did a bunch of squats with a 10-pound weight.
Wow.
So kind of describing, but you know what? He has stuck with it and he loves it. So I think
That's
it was
amazing.
Getting over that kind of first shock to the system of kind of this new medication.
I will have a 4th one coming soon, but she's currently pregnant. So she's looking forward to starting after the baby. It's a husband and wife couple that I'm starting. So they're excited about that.
That's really neat. And I will say that that spreadsheet was not 100% organically my brainchild. I derived the layout of the spread of the one I put in the slide from another group who had presented a poster at a former conference, and I just kind of adapted our current tracking sheet to meet that, and like, oh, they track like their date of application and all that sort of stuff. So, but it's been kind of interesting to put all that stuff together.
Yes, thank you so much, Lindsay.
You're welcome.
Hey, Lindsay, this is Dwight Rackley from VCU down in Richmond. I work with Dr. Fulco. Do you know Patricia Fulco?
I'm familiar. I don't know her personally, but I've read a lot of her papers, and my students know her. So.
Okay, awesome. Well, I previously, before I took this position, I'm a nurse practitioner. I worked with Dr. Fulco in our clinic. And so I've been working with her for trainings for VDH for different advisory groups on Cabenuva. And so I've been relying on her to see how our clinic at VCU is, and I mean, we're like mirror image. I think we've got like around 10 patients. We've gone through the same hurdles you guys have gone through, the process, the nursing shortage, the point person to be, who's doing this, who's doing that, and all the insurance issues. So yeah, I mean, it's the exact same thing here at VCU, and it's been a struggle, and we've had one patient who actually declined to go on it after his copay was going to be about $70 a month. So he was like, no, I'll just stick with the pills. And so it was more of a financial thing for him.
Yeah.
But the other patients are doing very well, but Dr. Fulco does an extensive, check on previous antiretrovirals, genotypes, history and everything to make sure there's no, resistance anywhere along the line, because we've got a lot of patients here that have been here for years and years and years that now are just coming forth and saying, yeah, I want to give it a try. And, but, Dr. Fulco has to give her, stamp of approval first to make sure, you know, it's okay. But yeah, we're right there. We're going through the same thing you guys are.
So we can, you know, collaborate and commiserate together when we need to.
Absolutely. Absolutely. Thank you. It was a great presentation. Thanks.
Thank you.
Thanks, Jasmine. That was very good.
I think we have a little bit more time, but yeah, I totally can agree with all the hurdles and everything that is we've all gone through. Interesting about that copay, and I think something that's interesting too, and I think I may have highlighted this in the slides, that there's several resources that can lower the drug copay, and, you know, potentially that patient wasn't eligible for that. But then something they do also have to consider is the potential like medical visit copay and the injection fee copay, which you don't have for oral regimen. Exactly. So that could come up as well, especially for patients that are not Ryan Way eligible to necessarily assist with, you know, any of those like bills per se.
Well, that's been an issue for us as well, because we see a lot of patients that live a good distance away from downtown Richmond. And so in order to drive, 30, 40 miles once a month to come down here just to get a shot, come to the clinic, and then drive back, it can be a time thing, a money thing, too, but it's a lot of patients, it's a lot of education, teaching the patients where it's just not as easy as once you get to first, you can do it at home. No, we haven't gotten to that point yet, but that's a common question about whether or not you can do it at home. Because they think, well, my grandmother, she gives her, Aunt so-and-so gives her insulin. Why can't I just give this? Well, it's a little bit more complicated than that.
Insulins are quite short acting.
Right. And the very first time we gave our first Cabenuva injection to a patient in the clinic, I was over there with Dr. Folco. And it was a good 20 to 25 minutes before the patient even, between, the mixing and the, getting the shot ready and getting the nurse ready. And it was a good 20 to 25 minutes before they even got the injection into the patient. So it's not like the flu clinic where you just come in and get the flu shot and leave. It's not that easy.
Absolutely.
And
like, have you ever tried to mix it, like to draw it up yourself? Like you gotta fight with it. Like it's not the easiest.
That's exactly what Dr. Folco was. She sat there and she was just, constantly, she's like, this is not easy, trying to, because which rilpivirine, I think, is the thicker, right?
Yeah.
Mm-hmm. Yeah. So
I draw that one up first.
Exactly. So yeah.
If I ever do it, usually my nurses they're just like fantastic and they're on it and they're so much better than I am. But if I draw it up to help out, I'm like, oh, this is like.
But that's the other thing too. I think you might have mentioned it. That there's a time period too. After if the patient doesn't show up for a certain amount of hours, that you have to discard the drug.
Yeah, we don't even start to draw it up until they've shown up.
Right.
And sometimes we try to make the most of their visits when they do come. Like if it's about time to get labs again, we have a phlebotomist in clinic. She's fantastic. We can try to knock that out as well. If they need any of our ancillary services, like the one I just onboarded, he meets with our substance abuse counselor. He meets with our psychologist sometimes. Like we can keep people occupied, I guess, during that.
Yeah.
Right.
And I guess I heard your comment about Dr. Folco having to kind of give the seal of approval. And I actually just the other day built a new screening tool in Epic alongside one of my NPs that I work with after we talked about making a little checklist. I made kind of like a yes/no screening checklist that providers can potentially use as an Epic dot phrase for kind of evaluating all the clinical caveats.
Right.
Is that, can you print that out?
If somebody has more questions.
Are you able to print that the checklist off?
I could try. Yeah, I can probably convert it into like a Word document or something. I could find a way to do it to make it not look super messy. I'm trying to get it a little bit more formatted in our EMR to look a little more like readable, but I could definitely forward the skeleton version of what I have.
I know due to the timing and sometimes with patients no showing, I don't pull out the medication until they arrive. Until they're checked in, I don't do it. But to waste time, like you say, I also drop labs. So if they need lab work, I start doing their lab work and other things they need. Or if I need to do an assessment or 6-month research, I would do anything in the middle of that time frame in order to help that, 15 minutes or so go by.
Definitely. Do you have them hang out for a little bit after their injections to monitor, or is that only with the first dose?
We did it with the first dose. I'm not sure. She probably got lab work today. There's a possibility she hung out a while today. Yeah. So yes, they probably will hang out, or until the providers tell me they want them to not. then they will probably hang out.
Yeah, they for the first dose at VCU, they hang out, I think, 15 to 20 minutes, something like that. But, you know, a lot of times they're seeing their, you know, case manager, getting their lab. So the 20 minutes flies by because they've got other things to do when they're here. Thank you so much.
Dwight, this is
Evelyn, I have a quick question.
Yes.
Do you guys have a pharmacist on site similar to, you know, Lindsay sits in our clinic. Oh, you do?
They
Yes,
do.
yeah.
Okay.
Patricia Fulco. She's
Okay. Got it.
Yep.
That's helpful. I mean, Lindsay, we've found Lindsay is just, I cannot tell you how many times I go to her desk and or every provider just zooms to her desk like every 5 minutes, you know.
Yeah, the same with Dr. Fulco.
Yeah, she's so beneficial to us.
Busy.
Yeah,
Yes.
yeah.
Mm-hmm.
It looks like we have time for one more question. Anyone else? One or two more questions if they're quick. Anyone else has anything else to ask? Otherwise,
hello, everybody. Can you hear me?
Oh, sure. Yep.
Hey, this is Shayla. Getting back to Cabenuva, we have not started it yet at our clinic. We have sent out the qualifications that are needed, and we have a few clients that are interested in it, but we have not started it yet. So we're just looking forward to, you know, whenever we can start it and seeing how many clients will want to participate in it, because a lot of the clients, I know at least 2 of them, they said they're just tired of the pills, but you also have to be qualified to get the Cabenuva. You just can't say, well, I'm going to stop pills and get the shot. You know, you got to have that viral load. You got to be consistent. So this was a great presentation. I learned a lot. Thank y'all so much.
Yeah, it's really hard because, you know, the clientele that it's best for may not have undetectable viral loads at that time. In fact, the one that I just onboarded, he has struggled with adherence as long as I've known him, and that's been a long time. And it came down to, for the last few months, one of our community health workers was calling him every single day to have him take his ART to keep that, to get that viral load down. And finally, after 8 years, I mean, granted that he's had no treatment failure technically, since he just wasn't really taking the meds. But it finally came down to a range where he was eligible. And we were like, we got to jump on this. We got to get him while he's got that motivation and get him started. So, and while he's on the oral lead-in with the 2 pills instead of the 1, we're going to have that kind of close daily, probably texting or calling, and a real intense coaching as well. And sometimes that's just what it has to come down to get those patients started, because it's such a double-edged sword, being that it's such a great regimen for patients that don't like taking pills, but you have to have taken pills really well first to get to that point in the first place. But maybe there'll be more data in the future with viremia. We can only hope.
With that, I think we're out of time. Thank you, Lindsay and Jasmine, for your presentations, and everyone for the thoughtful questions. Evelyn, you unmuted yourself.
I was just gonna
tell Sheila that, Sheila, you're in good hands with this team. I know you guys are just starting out to get your process going in your clinic. You've heard from Lindsay, you've heard from Dwight. If you have any questions, and Tamika as well, reach out if there's any best practices we can share. We're more than happy to support. But I believe you're in good hands, and I'll work with Brad to make sure that we get the presentation to him to send out to the group. So, but thank you so much, everybody.
Thank you so much.
Absolutely.
Thanks, and I believe you have a 30-minute break now until the next presentation, which is on Provide, and that'll start at 2 o'clock. So reference your agendas, and yeah, thank you all. Have a great rest of your day.